My name is Denysse. I'm the Director of Operations for CareMax Medical Centers. I've been working here for close to 3 years now. And as far as healthcare-wise, I've been in the healthcare institution and in the same realm for about close to 15 years. And within those 15 years, I've really have had most of my experience with the Medicare Advantage world that we're going to be speaking of today. So in today's presentation, I'm going to review with you guys kind of our customized, again, model for Medicare Advantage. How are we managing, or kind of an explanation of managing Medicare Advantage members. And finally, the Medicare Advantage templates and workflows that we designed. Okay, and taking a look at kind of who and what we're about. We're 7 full-risk clinics here in South Florida, specifically in the Miami-Dade County and Broward County area. So our practices run from all the way, if you know the area, close to the Homestead or Florida City, close to the Keys, and all the way up to the Plantation and Broward area. Being full risks, we like to include all the services that you see on the screen, inclusive of transportation. We have a fleet of about 50 vans currently now, lab, urology, primary care, pain management, diagnostic radiology, inclusive of x-rays and ultrasounds, gastro, cardiology, and most recently we're doing home visits. In addition to all the services that we provide medically, we also have an adjacent to all our practices things that are called wellness services or wellness centers, in which we like to engage our patients, keeping them there kind of in a social setting. I don't like to call it an adult daycare center, but more as a social gathering or an area in which they feel like they're part of the family, they're at home, and as well as receiving their medical care, they also have a time that they can be reunited with their friends, and certain activities are provided, inclusive of exercise classes, diabetes programs, or kind of seminars, spa services. We do have, they can do their nails and their hair, and social services provided down here, which is called Access, which provides any additional help that they need for this type of population. And inclusive of that, we also provide for them breakfast and lunch, which they really enjoy. So managing our Medicare Advantage members in comparison to fee-for-service. So if you've never heard of the term Medicare Advantage, it pays a cap amount per member, per beneficiary monthly. It focuses on preventative care or proactive care and early intervention. We like to incentivize with care coordination and innovation, and we use a risk adjustment model for patient differences. We really did this kind of comparison at the time that we set up these slides when we were at UGM, and we picked kind of our baseline for Davidson County, which is, I believe, in Nashville, Tennessee. And just to give you kind of a base rate, their cap rate per member per month, they would receive $844.61, again, per member per month. And we kind of wanted to give you an idea of what that looked like across the country, stemming from down here in Broward County all the way through California, Orange County, which is Orlando, and then a few other places like Arizona and Illinois, just so you can have a comparison of if you get onto this type of method, which is Medicare Advantage contracts, this is what you could be looking at a per member per month rate. Now, these fluctuate per county, depending on what county you live in. Some may be lower, some may be even higher than these rates. I know Dade County, for example, is higher than the Broward County rate. So it does define itself by the county that you're in. So a lot of what we do is an accurate HCC coding system. So the risk adjustment factor, the RAF score, is based on how well you diagnose at the point and document at the point of care. So, for example, here's kind of a very brief scenario of a female, 76 years old, who's Medicaid eligible. She has diabetes with complication and vascular disease. So it kind of comes up with a point system. The other part of Medicare Advantage of what encompasses your payment is the star ratings. For us, most of our members are joined with HealthSun, who's a big Medicare Advantage plan down here. So if we manage our HEDIS scores, we also receive a star rating or a system in their star rating. Currently, they're a 5-star plan, and that generates an additional bonus for the providers that are servicing these types of patients. And actually, it's up to 5%. So if you get a 5-star rating, then you do get that 5% bonus in addition to your payment. So here's kind of a way that we've been able to optimize our Medicare Advantage premiums. So again, taking the sample of Davidson County, which is Tennessee, their base payment per member per month is $844.61, but they were able to gather some risk adjustment factors that gave them an additional $797. And then finally, because the provider itself scored about a 3.5, they got an additional bonus, which per member was an $80.22. So really, per member per month for this particular scenario would give you the $1,800 mark, as you see. So kind of a comparison to what you're looking at from fee-for-service to Medicare Advantage minimal coding to a full managed Medicare Advantage program that we have. Fee-for-service, you're looking at for 200 members, no cap rates, your usual codes of initial visit, follow-ups, about 2 procedures. So you're looking at about a $41,600 a month rate. Of course, that's $500,000 yearly. If you do belong to a Medicare Advantage program and you do have that contracted rate with your your payer, for 200 members, you'd be getting that $844 for a PMPM rate for an annual visit. That'll generate that rate per month and a $2 million profit per year. And finally, our model, which is fully managed as a Medicare Advantage program for 200 members, because we do so well with the ratings, with the scoring system, with the documentation, it could go up as much as an $1,800 mark and about $4,500,000 yearly. So here's kind of a brief scenario of the value of HCC coding. I'm not going to go really into it, just so you can understand where's the point system and what does that entail per scenario, with the first column being no conditions coded, some conditions coded, and all conditions coded, kind of the difference of how you can improve your scores. So finally, because we wanted to really maximize our systems and take advantage of the Medicare Advantage model, we needed to do a few things and really target, once we went live with NextGen, some points. So this is what I'm going to be showing you today, is how we track our HCCs, our drop-offs, our suspected codes, and overdue codes. And we do that at the point of care, so the physician, once they are documenting and seeing the patient, they know exactly what they have to be reminded of as far as HCC codes are concerned. We had to implement coding review processes between the provider and coder. A lot of times, if you're not in the same office, you need that dialogue between your physician and coder. So we had to come up with that, an efficient system. We needed to improve coder training. And then finally, we had to create EHR templates to align all these workflows. So the first thing we do here at CareMax is we have a process for pre-audit. So the coder goes in and knows the physician has a set number of patients for the following day. And seeing the patient as a whole, they take a look at the provider's scheduled day through their inbox, of course, and they start to conduct a pre-audit review. They create a new encounter. We have them using the visit type of chart update. So it's not a billable encounter. And what that does is that it generates this view that they can use called recommended diagnoses. Now, here's where the coder, based on their review of the patient holistically, they take a look and they say, well, this suggested code happens to be the E10.9. They did review it, or it's up for review based on this year of 2017. So they select that as a suggested code, and they add it so at the point of care for the physician, they're able to see that suggested code. The other option they have is also to select or input new diagnoses that they found, perhaps by doing a search or a scrub of the patient's record. Maybe they have gone to a specialist or a hospital visit and they found new HCC codes, and they are able to enter new ones and document the same. So what we wanted to do is really keep it simple for the physicians, and all these suggested codes that are coming from the coder and their pre-audit review kind of land in the SOAP template under a section called Outside and Suspected Diagnoses. What happens is the physicians take a look at this table called Outside and Suspected Diagnoses based on what the coder did probably a few days before, and they have the ability to see those codes, to select the codes and see the status. They're able to see if this is a new diagnosis or something that was reported in the past. They are able to either accept the code as is or also say no evidence of disease. So it really depends on their perception of whether this is a correct code, whether this is documented, whether they feel that this is valid. They are able to make additional commentaries, and once they hit save, then it drops into today's assessments. So this is really what we wanted to do, something that was pretty seamless for the providers, not as intrusive, and really maximize their time within the SOAP. So by having this dropped into today's assessments, then they really don't have to do their search on their own. It's really brought down towards them and easier for them to document and go on with their note.